Thank you so much, Joanna. Thank you for having me. Yeah, it's a real pleasure to join you all the way from the UK and to be part of this program. And I'm conscious that I'm picking up in the middle of a program and following on from other conversations you've already been having about sustainability and quality in clinical care. So I guess I'll bring a bit of a UK, a bit of our experience. And particularly looking forward to sharing with you our approach to integrating sustainability into quality improvement and what that has led to. So thank you very much for the introduction. I don't have anything to disclose. You've already said a little bit about our work at the Centre for Sustainable Healthcare, Joanna, and this is a little overview of the programs that we have. So we do quite a bit of work around sustainability in quality improvement in education and practice, which I'll tell you about, but we also have work in measuring the environmental and social impact of healthcare, and working with different medical specialties and working to make better use of the green space around hospital sites and healthcare sites for the benefit of health. So lots of things going on, and we've been going since 2008, and really we've always tried to bring that clinical care and environmental sustainability closer together, which I'll tell you a little bit more about. So the learning objectives for today, the knowledge, we'd like you to be able to describe lower carbon care through preventive measures, improve quality care, improve procurement practices, self-efficacy. So could you develop a case or a project for better care, for specific improvements, and communication? I hope you'll be able to better engage in dialogue with leadership to discuss opportunities for adopting climate smart clinical care practices. So a little bit about the context in the UK, specifically in England, because the National Health Service is a little bit separate in each of the countries of the United Kingdom, but they do all have commitments now to decarbonisation. But NHS England just about got there first back in 2020, and set goals around, first of all, the bit in this white box, so the scope 1 and 2 and a little bit of the scope 3 carbon emissions. So that's all the things that are directly emitted on site from healthcare activities, plus the electricity, the carbon footprint of the electricity that's used, and then some of the other emissions that it's felt that we have more direct control over. So things like metered dose inhalers, waste disposal, business travel. And then by 2045, there's a commitment to reduce the whole lot. So that includes everything in the supply chain. And it's obviously going to be a whole society effort for that. But I think the aim is that we should play a leading role in that transformation. So if you look at the breakdown of like what's contributing what to the carbon footprint in England of the NHS, you can see, of course, that clinical care has a lot to say about a lot of these different big categories. So obviously medicines, medical equipment, anesthetic gases and metered dose inhalers. But in fact, as soon as you think about it, actually it's clinical decisions that are driving the resource use in all sorts of ways, you know, from when you bring somebody up for an outpatient appointment or admit them, or you order investigations, and it's really, there's clinical decisions affecting resource use throughout the entire system. So even if you look at it from the point of view of a lot of this operational resource use, like things like energy and so forth, that actually as the end user and also the kind of gatekeepers, the clinical staff have a really important role in partnership with management to look at how we can improve things. But so I'm just going to jump up a level from the operational resource use, because actually that's part of a bigger picture. Oops. Which is, if you think of all those things, the energy, water, etc., down here, and zoom right out, you can see that actually we have a lot more different opportunities to reduce carbon by actually changing care itself. And you can see this is just a driver diagram. We've started by thinking, right, we're aiming to reduce carbon, but to improve health at the same time. We have a number of ways we can go about that. We could reduce the amount of activity in the healthcare system, and doing that in ways that improve health. That could be things like prevention. It could be things like supporting people to care for their health better, to be active in the management of their chronic condition, for example, or to participate better in decisions about their care, so that we're not doing things to people, we're doing them for them. And we can also, I mean, I don't know about where you are, but in the UK, you could definitely say that there is a lot of activity that's not directly contributing value to patients. A lot of duplication, a lot of low value interventions and so forth. And I think that that was one of the main focus of the last session that you had, is how you can make sure the care that you give is the right care in the right place at the right time. And then going on down here, we're still going to want to do some activity in healthcare, I think. So what can we do about making that as low carbon as we possibly can? And that's about low carbon clinical decisions. So we need to start knowing, in the same way that we wouldn't use a really expensive treatment in financial terms to achieve the same outcome as you could get from a much cheaper one, ideally. We don't want to do that with a very carbon expensive treatment. So we need to start knowing, which are the high and low carbon inhalers, the high and low carbon anesthetic gases. We already know those things, but also what about different modes of investigation, different treatment pathways, which kind of dialysis or transplant, or where you've got treatment decisions to make, which ones are higher and lower carbon, and how does that stack up with the clinical outcomes that you can achieve. So what we've found is that these principles are a way of interpreting environmental goals into ways of thinking that clinicians are familiar with and can incorporate into their practice. But they can also really inform how over time, we gradually innovate and improve our services. And actually, you can see sustainability. Oh, sorry, that one's got a. I wasn't expecting that to speak. Hopefully, it won't do that again. So we can see that from those principles that I was just talking through, you can see that actually there's many reasons to do those things, not just about the environmental resource use. They will actually, by applying those principles, you're making the care more patient-centered and so forth. But actually, sustainability is important too. It's important in its own right. We need care to be part of a sustainable future, and it can help us to achieve these other domains of quality. So it's part and parcel of quality in healthcare. And I just think that's such an important message, because when I first started working in this field, people are happy with the idea of insulating a building, for example. But then once you start getting close to clinical care, people are quickly thinking, is this a trade-off? You're going to ask me to give up some quality of care, or you're going to not do something for patients that they might need because you're cutting back on the carbon footprint. And actually, we really need to change that and look at how we improve care and improve sustainability together. And I think when we do that, that's when it's going to become possible for it to be just part and parcel of culture in healthcare, and part of education, and part of the way that things are done. So this is where I was going to stop talking for. So if it's part of quality, the nice thing about that is that, well, obviously it can then be part of quality improvement. And quality improvement, I'm kind of a fan of, because we've, we're way past the days when, you know, in the old days, you know, as an individual doctor had their own patients and practiced pretty much completely independent. We're all part of a bigger system, and healthcare improvement or quality improvement is where we take responsibility for making that system work all around us. And it's great because we're starting to teach people and help people and equip people to actually improve healthcare. And that, I just think that's exactly where sustainability should sit. And it should be done in an evidence-based way, and we should equip staff with tools to make change. So what we've published in the reference that's mentioned on this slide is a recommendation that we reinterpret, we redefine value in healthcare to expand. It's not just outcomes over costs, it's outcomes for patients and populations, and it's over environmental, social, and financial costs, if you will. And there's a lot of different dimensions there. We're not trying to cut it down into one number. We're trying to help people to look at things in a balanced and complete way, and to make sure that they're trying to hit all of those different goals in at the same time. So we're kind of pushing up value by either pushing up the outcomes from the same resource use, or ideally driving up outcomes at the same time as reducing resource use. So how do we do that? And what we propose is this framework for integrating into quality improvement. So it's not like a completely new methodology. It's embedding into the different steps that we already would do in quality improvement. So I've already talked about setting goals and aligning goals with that, the bigger goal of driving up sustainable value. And then obviously within QI, you need to set a narrower goal that you can that's addressing a particular problem, but it should be aligned to that larger goal. And to help set those narrower goals, then we need to study the system as it works currently, and we try and help people to look at the way that their care pathway or service is impacting on the environment currently, like which steps might be carbon intensive, which ones are creating a lot of impact on the social circumstances of patients and their families, for example. And then we use those principles that we were just I was talking through to help with identifying changes, and then those changes you then use all of the QI tools that we have to test out those changes and to see which ones are effective, and then implement them. And then when we come back to measuring impact, we're looking at the impact on all of these different elements. So and then we would present that at the end of a project. And that's something I'd really like to see in the future, is that if you ever pick up a report of a QI project, you would always know that when you got to the outcomes section, you would see the outcomes on the health outcomes, the outcomes for populations, in environmental, social, and financial impacts in that section. So we've been working over the last 3 years in both in healthcare practice settings, but also in education programs. And we've worked with quite a number of sites, about 14 different sites in the UK, some of them undergraduate, some of them postgraduate, some of them nurses and different AHPs, many of them doctors or medical students. And we have worked with the people who are teaching QI to embed it into their teaching. And we've published that in 2022, the results of a multi-center study. And there are a number of themes that came out. So one is that by integrating sustainability in this way, it helped the learners to develop a SUS-QI lens that they kind of couldn't unlearn in a way. Once they'd started to see things in that way, they started to notice resource use and opportunities for changing things that they hadn't been visible to them before. It actually increased motivation for taking part in healthcare improvement among this cohort. And that's obviously really important, because we need people to to get involved in QI, but it's a great thing that they find that it makes it more meaningful for them if you include sustainability. And actually, I think this one's really important, is actually there's a whole generation of people who are have really recognized how devastating the threat of climate change is, and can feel very powerless. And by equipping them with ways to actually contribute to a positive change, we're giving them hope, and I think that's important in its own right. So one of the other programs we run is called Green Team Competition, and we go actually nowadays we do it virtually since the pandemic, but we go into different hospitals and we support teams who put themselves forward from different parts of the hospital. We support them to develop a project using the SUSQI tools and methods. So I thought I would share some of those projects with you so you can see what it looks like. So I wanted to start with a preventative one. It's very much secondary prevention rather than primary prevention, but nonetheless, I think it is something that that sustainability is really good at, is helping people think upstream a little bit more than they were when they started out. And I should say that very often the teams come to us, they say, we've had a really good idea for a project. We're going to put recycling bins on the unit. And then we sort of spend some time with them and we say, well, tell us about your unit and the problems and things. So, and they come up with really interesting projects. So this is a project for patients who have an oral cancer, and they found an early side effect for them from the chemotherapy was the mucositis, and it's often created a lot of additional healthcare need, and nasogastric feeding and so forth. So what the team did, there was they introduced these self-administered sessions of photoiomodulation therapy. So and this was preventative to prevented them from many of them from developing the mucositis, and it just involves applying light, and it's done by the patient themselves. So I think that's a sort of a patient empowerment element to it, but it was done rigorously. They had, I should say, these competitions take place over just a 12-week period, and by the time they've thought of the project and what data they're going to collect, they only have a certain number of weeks, but in the time that they had, they really made a big difference. They had 11 patients in each of the arms of their project, and they were able to show in just such a small cohort of patients savings of £32,000, and if they extrapolated that to their findings to the full patient cohort that they treat each year, then there's £500,000 worth of financial savings. And then of course the carbon savings were also 2,600 kilograms of CO2 per year for just 11 patients, and much higher. And what we often do is we express the savings in equivalent of miles driven in an average car to help people to understand what that kind of carbon saving looks like. But you can see that obviously in a small project like that, it's not always possible especially within a short period, to measure the outcomes for health outcomes, but you can measure some surrogate outcomes like the need for nasogastric tube feeding and things. And you can also, I think they were able to measure a reduction in the number of admissions for complications. So this was a really good one that actually won the competition in their hospital, which is a cancer hospital. So that's just one example. I've got quite a few, so I'll rattle through some of them a little bit more quickly, and then we'll have time for some questions. So this one, again, it's another one similarly from the Green Ward competition. And this was early mobilization on the cardiac intensive care unit. So after cardiac surgery, they had a problem with a lot of congestion on that unit and difficulty with stepping patients down because they didn't have step down beds available. And they came up with the idea that maybe if they rehabilitated people more quickly on the unit, they could actually step them straight all the way down to a normal ward without a high dependency bed in between. And so they drew learning from other from the critical care unit within the same hospital, where they were doing more active rehabilitation on, and they introduced physiotherapy as a standard, and every patient, as soon as they met the protocol criteria, would be started on twice daily rehabilitation at the highest level that they were able to do. And they found that they reduced ventilation days and overall cardiac intensive care days, and actually that of course adds up to a huge financial saving and carbon saving. Now those carbon and financial savings, in a way they're a bit notional, because you don't close that bed completely and save everything that was with it, but it might allow you to use it for a higher value use. So that's one of the things you do have to bear in mind when you're doing these projects, that you might be redeploying those resources. So you may not get an actual saving, but maybe overall, if the whole system can be made to work better and get better value out of those resources, that will help us in the right direction. So this is a project. It was really helpful actually to have a project that was led by an infection control team, because very often staff will be very upset with the amount of waste, but they'll often say the infection control team won't allow us to reduce waste because there might be a risk to infection control. So it was fantastic to have an infection control team actually leading the project, and they felt that they would find opportunities for reducing unnecessary use of personal protective equipment. So what they did was they'd started with studying the system, and they did a lot of observation of how people were using PPE. And they identified, I think, 7 different scenarios in which PPE was being overused. So that was things like to do observations and even to make beds, and other sort of non-invasive, or sometimes not even directly in contact with patients activities. And they also did some surveys of staff to see what they knew about when they should and shouldn't use PPE and why. And they found quite a low level of understanding. So they introduced some education, and I think this picture here is a screensaver that was put on the trust computers, and they had a number of different ways in which they reached people to tell them about when it was okay not to use PPE. And actually, one of the really important things was that if you're using PPE inappropriately, you're actually likely to be spreading germs, because you don't behave in the same way as if you touch one patient and with your bare hands before you touch another patient, you would be very, very likely to go and wash your hands. But when you've got gloves on, sometimes you observe that people don't always do that. And so actually it could be contributing to cross-infection, which is obviously a very important message, both for getting people to engage, but also in its own right. So they weren't able to measure the health impact in the time of the competition because it was too short, but they're planning to go back and measure that. So this was only last summer, so we haven't quite reached 12 months yet. But because they procure PPE very quite often, they were quickly able to detect that the procurement had started to go down. And when they observed on the same wards where they'd been carrying out the education, they observed an even greater reduction. So they're expecting the procurement data to come down even further. and they've extrapolated their findings to 12 months. So we try and do that for consistency, even though we recognize it's going to be a projection. And so that's where they found from these small changes, they extrapolated that we expect to save lots of money and 26,000 kilograms of carbon dioxide equivalents. And as often find, when people have a positive, feel that they're part of a positive change, then they're motivated to get involved with further changes as well. Apologies. Yeah, so there's another, this is another kind of lean care and patient empowerment example. This came from a sexual health and HIV service across a county in England, and essentially identify that HIV patients were very stable, with good, well-controlled HIV, were having exactly the same care pathway and frequency of attendance to outpatient services as people who were just started or who were not stable. And so that seemed like an opportunity. And the implications for that, the sustainability wise, is, patient travel to appointments, but actually also equipment, because they were having blood tests as part of their appointment. And what they did was they got the concerns from the service together and agreed a definition of a very stable patient, and they developed a new pathway, which instead of 6-monthly doctor review and phlebotomy blood tests, it was once a year you would have the doctor review and blood test, and then in between at 6 months you would just have a telephone call with a pharmacist. And they were able to, if you think about the impact on health, it was actually an incentive, because patients didn't actually like coming for what was a low value appointment, and if they could show that they could get to a stable, to meet the criteria for stable patient, then they could drop down the number of appointments. So that was has a potential to improve patient adherence, and it saved a lot of time, and it allows people to invest their work time in higher value, helping people who are not stable or at the beginning of being established on treatment. And that was important because the service was under strain, and that was creating a lot of stress for those people working in it. And it saved a lot of carbon just because of the number of patients, which I can't remember the number of patients, but I think it was around 800, and quite a lot of money. I'm aware that our health system is publicly funded, so when you save money, you're saving kind of public money, which might not look the same depending on how your health system's arranged. But so that's something that I think is looking to be rolled out probably nationally. There's a lot of interest in doing that. I couldn't really give this talk without mentioning inhalers, because such a big part of the carbon footprint of the NHS. And this example is from Wales. In Wales, they have set a goal of reducing the rate of increasing the rate of dry powder or soft mist inhalers. So reducing meter dose inhalers that have the propellant gases that cause the climate damage, and 80% prescribing of non-propellant inhalers by 2025. So they were nowhere near in line with this. At the moment, it's the other way around. And they also identify that quite a lot of patients have poor asthma control, and you can sometimes recognize that because of the number of SABA inhalers that people are being prescribed. It could suggest that they are wasted because they're not using them, or they're using them and that means that their asthma is uncontrolled. So there's an opportunity there to tackle both in sustainability and quality of care. Yeah, easy. We're tackling the 5% that's coming from anesthetics and inhalers. So there's actually a whole range of ways in which you can improve care and sustainability at the same time. So they introduced a pilot clinic that had a kind of decarbonisation goal, and they did this in a primary care setting, and they started by inviting patients who were being prescribed 6 or more salbutamol inhalers each year. And the opportunities they had to improve care were putting people onto MART therapy, which kind of better adherence, and because otherwise quite a lot of people just use their reliever and they never use their preventer, and you can achieve much better control if you can get them onto MART. They get education on how to use the device correctly. It was being run by a pharmacy technician, which is not causing additional burden on doctor time and nurses. So it's good use of their skills. And then in terms of low carbon alternatives, that's where they followed the Welsh guidelines to switch those patients who are appropriate onto non-propellant inhalers. And they were able to also take the opportunity to let people know how important it is to return your inhaler to be either recycled or destroyed, in order to destroy that residual greenhouse gas that's in it. Lots of opportunity for improving health outcomes there, and this was just actually I think that I'm very modest saving in the small amount of time where this clinic was piloted and the small number of patients they were able to reach. But if you look at across the whole area that's served by that health board, there's potential for really huge carbon savings from doing this because of the high carbon impact of inhalers. And actually, I've been involved with trying to help get people to take action on inhalers for a long time, and it's been really difficult because it's just really complicated. It's embedded in a lot of different clinical care. If you just make a change, it could have an unintended consequence, and there's been a lot of concern about people have taken trouble invested a lot in standardizing inhalers, and now you're coming along and introducing another one, and so that actually bringing it together with really improving care and outcomes for the patients has been the breakthrough, really. I think that we're starting to see how it's going to change, and patients have been I think patients have benefited. This is on anesthetic gases, and it's just to remind that it's not just about choosing a better anesthetic gas, but actually in this particular service in London, there are a proportion of patients, even who are having cataract surgery, who are being listed for general anesthetic. And actually, when they looked into it, it was often to do with patient anxiety that hadn't been addressed, and that had or lack of knowledge among the person who's doing the consenting about what techniques the anaesthetist can use to do the surgery under a local anaesthetic. So actually you can avoid the general anaesthetic altogether, and that has much greater savings than just choosing a better anaesthetic gas, because it's obviously avoiding all of the other equipment that's used and theatre time and everything. So the intervention actually centered around having a better initial consultation and consent process with patients, and again, with just quite small numbers, they were able to save a lot of money and carbon, and actually you're reducing operative risk and you're reducing waiting times. And at that time, it was right in the middle of COVID pandemic, reducing the risk of hospital-acquired infection and COVID transmission. I think this is my last example. I just wanted to have one from mental health, which is just to say, and it's actually a composite example from lots of 8 different mental health sites. But it's a project that we supported for them to, and the motivation for it was actually came from the poor experience of patients in mental health settings, that they were having, that they were in a not a very therapeutic environment, and the quality of relationships with staff was poor. And there's quite a lot of studies that have shown this. And actually, by providing meaningful activity and access to nature, we felt that you could help to address some of these things in a really low cost, low resource way. And actually, when you think about it, it can be part of prevention, self-care, preventing, if people can use it to help build resilience to further mental health crises, and if you can avoid readmissions, and it's obviously quite a low resource intervention, taking people from the ward. And just was really, we did quite a lot of qualitative data collection with those different sites, and the richness of that data was amazing. That really spoke to the opportunity, the therapeutic space, and the quality of the relationships that are built when you're walking alongside people and alongside staff, and take them out of the clinical setting. And also for many patients, it really gave them an opportunity to, sorry, I've got my helper, to connect to themselves as they'd been before they were a patient, just as a person. And so and it was really the evaluation very much based on qualitative data, and rather than quantity. There weren't a lot of financial savings, but certainly there was some qualitative improvements to the atmosphere on the ward. And I think over time it'd be possible to collect things, data such as violent incidents of violence and that kind of thing, that would be really interesting to look at in the future. So we're looking to continue this work. Okay, I thought that was my last example. I think this is my last example, and I think it's really because a lot of the other ones have been about the patient pathway, and this is really a lot more about how clinicians can influence procurement and use of equipment. And this was a home enteral feeding team, and they really wanted to reduce the amount of waste, and actually their patients felt the same way. So they knew that that would be important for their patients as well. And you know, just a couple of small changes that they were able to make in that short time frame of the competition. One was that there was some recent research that the giving sets they were using, which had been previously classified as single use, could actually be reused up to a 24-hour period. And there was also a reusable feed bottle that had been introduced, so they were able to introduce those things. And then actually, by reducing the amount of equipment you're ordering, they we're hopeful that in future they'll be able to reduce the frequency of deliveries of equipment as well, so you'd get some additional savings in the transport. So here it was really not about improving the outcomes of the patient, but it's just, you know, as long as you're not harming them, if you're creating resource efficiencies, then that's all good, and you're doing well on the value equation. So what I'd really like to leave you with is, what opportunities do you see to improve sustainability in your own clinical area, and how could you perhaps use quality improvement methods to make some of these changes? And part of that, one of the interesting things to think about is, what would you measure? What will you measure? There are some resources to help you. I think the most valuable thing might be to go to the hsc.unm.edu website, and it's got a lot of step-by-step resources for people who are working through a quality improvement initiative, and also case studies. And one of the things you'll see down here is a link to CSH networks. So we have about 30 different networks with shared interests, many of them specialty based. So that's a really good way of finding out what other people are doing and sharing what you're doing. And thank you very much. I'll stop there.
Thank you so much, Dr. Mortimer. Unbelievable. Gosh, we've learned so much today. We're learning so much every week, but today was really, really special. I guess for two reasons. One, we learned so many kind of exemplars of what different people in the UK are doing, not only in England, but also in Wales and other parts of the UK. And the UK in general is just really on the cutting edge all over for the globe, really, in what you're doing. I do want to start out with the first question and then turn it over to my colleagues Kathy and Stefan. You know, many organizations in the US have, you know, lean QI teams, lean teams, Six Sigma teams that are working in QI projects. Do you think that these SES QI projects, these green QI initiatives, can be incorporated into these, if they're working well, these current, you know, Six Sigma teams, or do you think they should be kind of a separate entity? And then I guess the second part of my question is just any thoughts. This is a very general question, but why do you think, I mean, I'm sure that your Center for Sustainable Healthcare is part and parcel of why the UK is moving so fast in the area of, you know, the climate change rules and regulations. But yeah, so just wanted to ask you more about these SES-QI teams and how they could be incorporated in the US.
Oh, thanks, Joanna. Yeah, absolutely. I just think it should be all part of quality improvement, whether that's being done as through Six Sigma, Lean. You know, I think it should just become part and parcel of that. And I don't think you need a new team. I think it's that same team that we can help them to gain knowledge around where are the environmental impacts and how might they go around measuring it. And so that's what we're doing now. And we're moving on from just working with those teams on the ground and supporting them to do projects. I mean, a lot of the reason that we were doing that work is to demonstrate that it actually can be done, and to also to create local examples that can be shared within that organization to say, look, this is part of clinical care and clinical improvement. But what we're actually wanting to do is to show this can be done, and actually it's a really good way of doing quality improvement. So what we've done in the last few months is we've set up a SES-QI Academy, which is for organizational leads who are embedding sustainability into the QI work or QI programs in their organization, and we provide them with mentoring and training and an opportunity for them to discuss with one another how they're doing that. So yeah, absolutely, I'd love to see it as just part and parcel of how it's being done, how improvement work is being done.
And I'm going to sing your praises. Your organization has lots and lots of trainings for health professionals to get more knowledge in how to run these programs. Thank you so much. I'm going to turn it over to Kathy. There's lots of amazing questions.
Yes, thank you so much. I wanted to dig into telehealth. We had some chat interest in that, and it seems like it is kind of a mixed bag. I've seen studies, at least in the US, that telehealth doesn't even really reduce automobile trips because it's often used when an appointment would not have been made in person. So, and you know, is the care really equal? But I guess I'm curious, how you think about telehealth, how we can actually have it be both better for care and better for the environment. And maybe even if you could talk about, in the long run, if people are getting care in a way they wouldn't have received care otherwise, if that prevents an illness, how do we think about that much larger way of reducing greenhouse gas emissions? It's not just about the auto trip, it's about, are people healthier? And is the quality of their care better? So anything else you can share with us about telehealth would be great.
Yeah, that's a great question. Telehealth's not just one thing, is it? It's the use of telecommunications within health, and there's many health systems and pathways as you have. There'll be, telehealth could be used in different ways within each one of those. I think that with the amount of remote care that has been able to be provided with the pandemic, I think that has blown away a lot of the myths about what was not possible and what people wouldn't benefit from and wouldn't accept. So I think that's good, because I think it was being held back before that. But I think the goal always has to be to get the best possible care for the patient group that you're looking at, and then you think about how they can access that care, and they're not probably going to be a single group, are they? So you have to be able to be flexible about how different groups will access care within your pathway. So we have created a calculator to help people measure the carbon savings from switching from a face-to-face to a remote consultation model, and I can look up the reference for that. I think it's going to be difficult for Kent to look that up. I'll get it put it in the chat. But so you have to bear in mind that you're saving on the travel, but you might need additional hardware or data storage that does have a carbon footprint. But often what you find is you don't just completely swap out an interaction. You redesign things a bit differently, so you kind of combine a couple of things in a visit that would previously have been done on separate ones, and then that allows you to do one other thing either not needed at all or remotely by a phone call. And that's certainly one of the things that's been happening in the cataract pathway that we've been working with the same group that did the Keeping Patients Awake project, and just looking at actually you can triage you can referrals more effectively and actually screen out which ones do need to come in and have preoperative assessment and things, and which ones can be going straight through to a pathway, and which ones are actually needing something else. So actually a lot of the savings there are they're from getting somebody sooner onto the right pathway of care than they are from reducing the travel.
And this is Joanna. Sorry to interrupt, Dr. Mortimer. Kent put that in the care pathway.
Oh, well done. Okay.
Yeah. I just wanted to also let everybody know that Project ECHO itself, by training clinicians to treat patients in their own communities, also has data to show a reduction in greenhouse gas emissions because patients don't have to travel sometimes, 10 miles, 20 miles, 200 miles for a consultation. So there's lots of ways to look at telehealth in terms of being sustainable. Back to you, Kathy.
Yeah, I think you get the best learning in telehealth from those more dispersed communities, don't you? England's really small and places are quite close to one another, but Scotland's got some quite big distances and people on islands and things like that, and so they've gone ahead and we're now learning from them and catching up.
I'm going to ask the next question. Thank you, Dr. Mortimer. I'm going to ask a question posed by Preeti, which is more of a kind of practical question about how some of this is done. And I'm curious about this as well, but Preeti asks, are there rules of thumb for how to calculate the carbon savings? She says, we're quantifying drug wastes, but she says, I don't know how that translates into carbon saving, and just curious about how that's done.
Yeah, I mean, we do have some resources in the SSQI toolkit for how to think about a carbon study of your project, and we also, it can get much more detailed than that, and we run online courses on carbon footprinting in healthcare. In general, the thing is, when you're looking at a really individual change, like I don't know whether you're looking at a specific drug and reducing the waste of that, unless it's an inhaler where you've got a greenhouse gas that has an enormous carbon footprint. So like each inhaler, you can measure quite a bit of carbon savings, and then if it's just another product that doesn't have that, it's probably going to be very difficult to get an accurate carbon emissions factor for that specific product. What you would need is for the manufacturer of that product to disclose a lot of information that's often proprietary. So actually it works. There's a couple of things you can do. You can measure the amount of the product that you're saving, and then let other people turn that into carbon when the data becomes available, or if it does. Sometimes what we do is we multiply it by a generic figure for if you spend X number of pounds in the pharmaceutical sector, it's likely to have an approximate carbon footprint of Y, and that is problematic when you're talking about individual drugs, because it's about the entire sector. And then the other thing would be to work with suppliers and get a proper life cycle analysis of that product. And there is a database that's been launched recently of life cycle analysis studies in healthcare, and so it might be someone's done that study for you. So that's already worth looking up, because it's quite hard. It's quite a lengthy process to go all the way back into the manufacturing process and all the raw materials and everything to get an accurate figure.
Thank you. I'll pass it on to Joanna to wrap things up.
Okay.
Oh, great. Dr. Mortimer, thank you. Thank you so much. We are so delighted, humbled, honored that you came and gave us this talk all the way across the puddle, as one would say. And we wanted to remind folks that the post-session survey went into the chat several times, the first time being 45 minutes after the hour. We know it's way past dinner time for you, and so we're really grateful that you could be with us during your family hour. So thank you. Thanks for all you're doing. Thanks for being on such the cutting edge. We will share all the programs that you have at the Center for Sustainable Healthcare in Great Britain, in Oxford, and maybe all of us could take a field trip to visit you at some point. That would be amazing, on a boat, of course, on a sailboat, of course. And so thank you. Next week is John Utek from Cleveland Clinic, Emily Sine from Mount Sinai. They're going to be talking about carbon accounting, ESG, and giving examples of institutions, including Cleveland Clinic, that are doing things in a really fine way. So please stay tuned. We've got 4 more weeks of this series and look forward to seeing you again. Thanks again, Dr. Mortimer. Thank you.